Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, pre-health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Archana Bindra. Dr. Archana Bindra is board certified in endocrinology and internal medicine. Dr. Bindra attended medical school at Seth G. S. Medical College, King Edward Memorial Hospital, University of Bombay, Mumbai, India. Dr. Bindra completed her residency at the Department of Internal Medicine, Los Angeles County, and the University of Southern California. Her fellowship was completed at Cedars-Sinai Medical Center, UCLA. Dr. Bindra currently practices medicine in the field of endocrinology.
The topic for today is partnering with your doctor to improve control. Diabetes is a disorder that doesn't speak for itself. So when you go to the physician, unlike a cold, or if you've broken your leg or you've sprained your ankle or something, when you walk in, if you've broken your leg, it's very obvious. If you've sprained your ankle, it's obvious. If you have a cold, it's obvious. But if you have diabetes, it's not obvious. So unless you come in and you say something more than I have diabetes, nobody can really help you. So that's what this whole talk is going to be about. We're going to talk about a typical doctor-patient visit. And nowadays, doctor-patients, to get a hold of a doctor is hard. To meet with the doctor long enough is hard, and to get your point across is hard. So this is a typical doctor-patient visit that you're going to hear about, which hopefully none of you have had this kind of an encounter, but this is not unusual, and we get this at least a few times a week. So let's go. So the doctor says, Mr. S, how long have you had diabetes? And Mr. S says, around 4 years. I was on some pills, then started insulin. So the doctor says, what were the names of the medications? Mr. S says, I don't know. There are a couple of green ones, a really small red one. There were 2 bottles. One was cloudy, the other was clear. So the doctor said, oh, okay. So the doctor says, do you check your blood sugars at home? Mr. S says, no, not really. Do you have a glucometer? Mr. S says, not really. I've used my uncle's glucometer on an occasion. It runs around 130. So the doctor says, do you have recent blood work? Mr. S says, yes. Doctor says, so what was your hemoglobin A1C? Mr. S says, what is that? The doctor says, well, I will explain. The doctor says, your blood pressure is high. It's 140/90. Are you taking your blood pressure pills? I am. I don't know what they're called. The doctor says, your cholesterol is high as well. Are you on a statin? I think so. How's your vision? Have you seen the eye doctor? Sometimes blurry. I wear glasses, but I haven't seen anyone in a while. How are your feet doing? Tingling? Numbness? They're okay. Doctor, do you get chest pains, or have you had a stroke before? No. So what we get out of this is that you've gone in saying, I have diabetes, and you walked out with nothing new. And you've been there about 20 minutes. The doctor has been there with you for about 20 minutes, and you haven't really achieved anything. So we see this all the time. I've highlighted all the key letters in red, which are all the key things you should be thinking about when you go to the doctor. You want to know the names of your medications. You want to check your blood sugars at home. You want to know what your labs are, your hemoglobin A1C at least. You want to know what your blood pressure is, your cholesterol is. See an eye doctor regularly. check your feet regularly. If you have chest pains or you've had a stroke before, you want to bring that up. So the main thing is you want to talk to your physician, okay? You want to bring this long laundry list. Don't make it too long, because otherwise that poor doctor won't get far anywhere in the, in the process. But you definitely do want to bring your list and do your homework when you come in, so that that visit doesn't turn out to be the way we just spoke about. So the main thing is to make a list and check it twice. You want to know the names of the medications. It's extremely important that you know the names of the medications, or at least even if you kind of remember what you're on, but if you know them, that's even better. You want to check your blood sugars. Make sure you're checking them and you're actually noting them down, and you're using your own meter. You don't want to use your brothers or your sisters or your uncles or your aunts, because the meter that you bring in should reflect your blood sugars. If it's a meter that belongs to an uncle, then you're going to see, one of you and one of the uncle, and then we have no idea what's going on. Because a lot of times these meters are downloaded in the offices. You want to know your hemoglobin A1C. You want to monitor your blood pressure, check your cholesterol, and visit the eye doctor once a year. Check your feet, and if you have hypoglycemic episodes, how are you going to treat them? So what is diabetes? How are you going to go in with all these questions if you don't really know what is diabetes? So diabetes is chronic. Diabetes is essentially a lack of production of insulin. So you don't produce insulin, or if you do produce insulin, it doesn't work in the way it should be working. It's not utilized correctly by the body. And what is insulin? It's a hormone that's secreted by the pancreas that helps decrease your blood sugars. Now, where is the pancreas? So a lot of people, they kind of don't know where the pancreas is. The other day, somebody thought it was somewhere right in the back over here, because he gets a lot of back pain and he thought the pancreas was hurting. But the pancreas is in the middle of your tummy, which is right there. That's your pancreas, that little thing here. The thing above it is the liver. This organ here right across, which is this organ here right across, makes insulin. And it also makes another hormone called glucagon. And insulin is the hormone that brings down your blood glucose. So if we take a look at this little cartoon, if you have a high blood glucose, it stimulates your pancreas to produce insulin, which in turn brings the blood glucose down. If it's low, it stimulates the pancreas to produce glucagon, which actually decreases the blood glucose. So insulin and glucagon, they work entirely opposite of each other. So essentially, that's how your body maintains a normal glucose level. So if it's high, it stimulates insulin, brings it down. If it's low, it stimulates glucagon and makes it go higher. Now, when we think of having diabetes and somebody walks in and says, oh, I've just been having some high blood sugars for the past 10 days, and I was diagnosed 10 days ago. The patient was not diagnosed 10 days ago. The patient has had it for about 10 years, probably. It's just that the body hasn't had a chance to, it hasn't surfaced out, or it hasn't been noticed until 10 days ago. And so when we take a look at this graph, the top graph talks about the glucose, and the bottom graph talks about the functions of some certain cells that secrete insulin. So if we look at this top graph, if you look at the point of 0, well, the bottom one actually tells you how many years you've had diabetes, and then this axis will tell you about the glucose over here. So if you have actually diagnosed with diabetes at here, you've really been diagnosed way back here, which is almost 10 years ago. And if you notice that the glucose that first begins to rise is actually the glucose after the meal, which is your postprandial glucose, which is this orange colored line. It's already starting to rise. It rises much before the yellow line does, which is your fasting glucose. And what we call IFG is impaired fasting glucose, which is essentially the glucose that you find in the morning, which has already begun to rise, and it's between 100 to 126. Now, when you reach this point, you've already reached in the state of diabetes, and then you have uncontrolled hyperglycemia. Now, when you're talking about beta cells are located in your pancreas, and they secrete insulin. So if you correlate this red line along with this orange and this yellow, you've noticed that as these two lines start going up, the red one starts dropping, and that shows that your beta cells are not working anymore, and they are dropping, and you're not producing any more insulin. So by the time you are actually diagnosed, your beta cells are already at this point, which tells you that you've lost about 50% of your beta cells by the time you've been diagnosed with diabetes. So the time to really catch it would be way back here when you have that very, very minimal rise in your glucose. There's another concept called insulin resistance, and that is if, say, a normal person takes a unit of insulin, it would normally bring down your glucose, say, by 50 points. In a person who has diabetes, that 1 unit of insulin will probably bring it down only by 10 points because it doesn't do its job the way it should be doing, and it's a resistance to insulin. And what makes insulin resistance worse is obesity. So as you notice that the blue line is telling you about insulin resistance, it starts increasing. You start noticing the rise in your after meal blood sugars, in your fasting blood sugars, but then that insulin resistance just flattens out and keeps on persisting. Okay. So the main thing is to know the names of the medications. So when you bring your list of medication, make a list of all of these medications and bring them to you. Carry them with you. Try and know the names. Make sure you don't run out. A lot of times people tell you at the last minute that, oh, I don't have this anymore or whatever. I haven't been taking it for about a week. Well, that puts you back in, you almost go back a few steps from where you started. So you don't want to run out of your medications. So you want to keep a log. Nowadays, all these meters, once you check your blood sugars, they're stored in the meter. And if you bring this meter with you, then the meter can be downloaded at the office. Interestingly, we've had patients where they think that this thing doesn't store anything, and you wouldn't know what's going on. So they write down the numbers of whatever they think they want the number to be. And they don't bring the meter with them. So that's, but it doesn't really correlate with their hemoglobin A1C, and then we kind of figured out that that's what was going on. All these meters, they come with test strips, there are lancets, there's log books, etc. You could write it down, bring it. Writing is also a good art because then you can look at it and you can actually see the pattern of your numbers. It involves a simple blood prick on your finger. You put it on a little test strip and you insert it into the machine. It gives you the number. So know your hemoglobin A1C. What is a hemoglobin A1C and how far apart should we be checking it? You want to do it every 3 months, okay? And the reason why we do it every 3 months is because hemoglobin per se has a lifespan of the RBC, the red blood cell in your body, has a lifespan of 3 months, 90 days. And so this hemoglobin A1C, this A1C is tagged onto the hemoglobin, to the RBC. And so that's why it's checked every 3 months. So if you check it every month, you're going to get overlapping values. And I don't even know with all these new insurance changes if anybody would pay for it or not either. But it doesn't really help to get it done very, very often. So A1C, so a hemoglobin A1C, you would like it to remain less than 6.5. The higher it goes, the more danger it causes, okay? Now the questions of what are the definitions of diabetes? So if you're less than 100, you're normal. If you're less than 140, after a 2-hour test, you're normal. If you're more than 100, you're less than 126 in the morning, you have something called impaired fasting glucose. If you're between 140 and 200, you have impaired glucose tolerance. If you're more than 126 in the morning, and then you have the diagnosis of diabetes. If you're more than 200 after a meal, you have the diagnosis of diabetes. So essentially, more than 126 and more than 200 after a meal will give you the diagnosis of diabetes. If you're less than 100 in the morning, consistently, with less than 140 after meals, then you're doing fine. But lower the hemoglobin A1C, your glucose is at a lower level. And you can see that once you start crossing this orange line, you'll see how the numbers correspond. So if you have an A1C of 10, 11, 12, whatever, then your blood sugars are anywhere from 250 onwards. So for good diabetes control, you want to have before a meal less than 100, and 2 hours post meals less than 140, up maximum less than 160. Your blood pressure control is very important as well. Less than 130/80 is what you're looking at. For lipid management, they're really looking for is an LDL, and an LDL less than 70 is what they're interested. You might read somewhere LDL less than 100, which would be acceptable if you don't have any heart involvement. Now, what are the main complications related to diabetes? So diabetes affects small vessels, and it affects very large vessels. If it affects the large vessels, essentially you're going to get a heart attack, or you can get a stroke, or you get high blood pressure. If it affects your small vessels, it starts damaging your nerves, so you could get your nervous systems, and your feet could get damaged. If your feet get damaged, you get ulcers. If those ulcers don't heal, they get deeper. You could get something called osteomyelitis. It's not on this screen. It's where the infection goes down to the bone. If that doesn't heal, it may lead to gangrene, and then eventually it leads to amputations. You could have kidney disease, which eventually leads to kidney failure. They go on dialysis. You could have blindness in your eyes. It's very common. Of course, dental disease, erectile dysfunction, and depression. Depression is a very, very common component of diabetes. In fact, if one treats the depression, sometimes diabetes improves, because I think a person then feels like actually taking care of themselves. So the main thing is to check your feet. We're going to talk a little about microvascular. So checking your feet is extremely important. You want to do it. You don't have to do it every day. You don't have to stick your feet out, but you want to make sure that you're not getting any sores. You're not walking barefoot. We had a patient who walked barefoot in Las Vegas in 100 degrees in the summer and had third-degree burns. Now that was not a very smart thing to do, but he did not feel the ground at all because he had such extensive diabetic neuropathy. So you don't want to walk barefoot in 100 degrees. You don't want to walk barefoot anywhere because if you do get hurt, then invariably that wound will not heal, especially with elevated blood sugars. So the main thing is to keep your toes dry. Look at your feet every day. You get these little gadgets that have little mirrors, and if you lift it up and you put your feet against them, you can actually see the bottom of your foot. This is a diabetic foot ulcer that you can notice at the back of the foot as well as on the side. It'll give you this kind of a punched out appearance because of lack of blood supply to the foot. And then it's these kind of ulcers that eventually go deeper. They involve the bone and they lead to osteomyelitis, which is an infection of the bone, which if it's not treated adequately, you can lose your foot. So we do start early as checking our feet. Eye checkup is very important once a year. So even the mice are telling each other that if only they had a regular eye exams, they wouldn't be blind. Now we have kidney failure. The most important cause of kidney failure is diabetes. If you can see here, it's 43.8%. The second highest would be secondary to high blood pressure. So there are numerous ways of treating yourself. You could do it in the form of pills. You could do it via injections, and as you can notice that this lady has an insulin pen by which she's injecting herself. You could do it in the form of a pump, and the pump is attached to the body by this little spaghetti kind of string, and the insulin is delivered through it on a constant basis. So those are your different ways of getting medication into you. Now the question is hypoglycemia. If you have a low blood sugar and you start feeling sweaty, irritable, can't concentrate, you know that it's going low, then the most important thing is to check your blood sugar. A lot of times patients come in and say, oh, I was low, I knew I was low, and so I just went and had a candy bar, And then the next thing you know, it's 350, and who knows what it was before that. So the most important thing is to check your blood sugar, and then it's a rule of 15. So you want to wait for 15 minutes for that to actually take effect before you check it again. So you check your blood sugar, you treat it, wait 15 minutes, and then recheck it again. And then if it hasn't gone up, then you would do the same procedure again. You have to remember, it's a treatment, it's not a treat, okay? So when you're going to treat yourself, I'm going to tell you what to treat with. You don't want to be treating yourself with, I had patients who, they wait for this time so then they can have, candy bars or cake or whatever they can find, but that's not really the way to do it. So the way to treat it is with 15 grams of carbohydrates, okay? So how do you get these 15 grams of carbohydrates? You could either go and buy glucose tablets, which I think are kind of an expensive way to go, because each glucose tablet is 5 grams and you need 3 of them to solve your problem. Or you simply drink milk. You drink about 4 ounces of skim milk or 4 ounces of orange juice. You could drink little juice boxes that you get out there. They have about 18 grams, I think, of carbs. You keep them handy. I don't know if 1 spoon of sugar would be easy to get, but that's another alternative. If my son was there, he would prefer the 6 to 7 hard candies, I know. But I think the easiest probably would be either milk or juice. But the most important of all of this is to recheck after 15 minutes so that you don't overshoot. It's also very important to keep glucagon at home. Just in case you pass out, then somebody at home needs to know how to administer glucagon. So glucagon is the opposite of insulin, as we mentioned. So it will raise your blood sugar. It comes in a pre-packed box like this, where you can actually see that it's all pre-filled. So all you need to do is sort of take it out and inject it. So diabetes essentially is a multidisciplinary team approach. It's not you going to the doctor and the doctor helping you, and that's the end of it. It involves a few other people. So the most importantly, it involves diabetic education. It involves a nutritionist. You need to see your ophthalmologist once a year. You need to visit a podiatrist for your feet. You also want to make sure that your medication, so pharmacy comes into play. So the visit is more of it's a comprehensive kind of treatment approach rather than just you visiting the doctor. So now you can see that the patient who went in the start of our talk to the doctor had a very incomplete visit because they didn't really take any of these things along with them. So if you took all your medications and you took all your, you knew what you were taking and you knew your labs and your cholesterol levels and stuff like that, then that visit would be a lot more comprehensive. And then we don't have to work 10 visits to take care of one problem. So essentially, this is the same thing again. It involves diabetic education. It involves medication management, glucose monitoring. It's very important that you check your blood glucose and you take that meter along with you. And if you don't have a meter, most offices have meters. They can get you something that your insurance will cover, and then you could get the strips. It's a very basic talk. It's very, it's sort of what the best that you could get out of your visit with your physician.